great case for you. It's a 63-year-old female, typical comorbidities. She's got a history of heart disease, diabetes, high cholesterol, hypertension, a history of a stroke. PK, she's even had a venous clot in the past, okay? So she was referred to me, and I feel like it's Christmas right now because these are the first pictures I've seen from her. She was complaining of left lower extremity claudication. There was a CTA that was done that showed a left common iliac artery occlusion and a 50% stenotic distal aortic stenosis. So let me show you what she's got angiographically, okay? And she's got two distal runoff, by the way, okay? So this is her first shot. I think you can appreciate that distal aortic stenosis that's calcified and a flush occlusion. It's relatively short. You can see where the internal iliac comes off and the external iliac bifurcation is, and the distal common iliac is patent, okay? This was done with a 5 French sheath in the right groin. I've now got a 7 French sheath in the left groin. And the question is could I cross this from the left common femoral artery without having to get brachial or radial access? So right now, I will tell you that I have gotten, I used a Mongo wire and was able to get the wire up. I used it with the support of a Navicross, and then I actually literally had to switch out for an 18-gram victory wire with a spinner. And let me show you this technology really quick. So remember, this is a spinner, just so you can see it. Literally, it's a super torquer that when you turn the device or pull the device back, it rotates 5 revolutions one way. You release it, it rotates it 5 revolutions the other. The nice thing about this device is it takes off the orthogonal friction of your wire. So, like I said, I had a victory wire in. Remember, this is an 0.14-inch polymer-coated 18-gram tipped wire with this, and it was able to glide through that lesion, and then I supported it with the Navicross and popped through. So that's where I am currently. PK, give me some help. What do you think in terms of therapy? So I think I've crossed the lesion, and I've got an Omni on the right, and then I got a 7 French on the left, so I can visualize from the right and treat from the left, I believe.
Well, George, first of all, incredible cross, and I'm sorry we couldn't demonstrate the spinner, but obviously it went very well. But we have an incredible panel here. We got a bunch of people. If you can show that aortogram again, I can ask them how they would treat, and then you can discuss how you're going to do it. So for the panel and the audience, this is the aortogram, and obviously Dr. Adams has been able to cross. So I don't know, any one of you want just go ahead and just jump in and tell me how you guys would suggest that Dr. Adams should treat this. You want to go ahead, Nico? Yep, go ahead.
All right. So, you have I have to say, this is a place where I start using, my shockwave, and first of all, dilate that with the shockwave, and then you can stent it, with whatever you're comfortable with. I tend, depending on the size, and if you have an IVUS, it will help us to tell what the size exactly is. But typically a short stent preserving the bifurcation is important. It keeps allowing you to keep working on the other side, and finish the left iliac territory. But that's going to be my approach.
Raj, as a surgeon, does that aorta bother you at all? You got a distal aortic lesion. I believe he's a claudicant, if I remember right. So, do you leave that alone and just open the iliac, or do you deal with the aorta at this setting?
No, I think you'd have to deal with that aorta. That looks pretty significant. I'm sure there's a pretty big pressure gradient across that. So that would have to be treated. I think shockwave would be a good option to try and open it up a little bit, and then plus minus, depending on whether you want some sort of stenting potentially, VBX, or open it up wide.
Dr. Jenkins?
So is there heavy calcium in this?
We don't have an IVUS. I don't know, George. There's a lot of questions on the calcium.
And I'm just wondering.
Yep. So I've got an IVUS PK. I was going to do that next. And then after I IVUS it, then we'll see what we have in terms of pathology of the lesion and where that common takes off. I would love to be able to not have to stent that right common iliac, but I may have to.
Right.
You have to,
Yeah, I agree. I think why don't you do the IVUS, and I'm just going to pick their brain, and you can listen to them as you're doing it, and we'll get feedback from you on your IVUS as well.
That sounds great. And if you want
So-
to do another lecture and you can come back to me with that after I get the IVUS, that'd be perfect.
That's perfect. But let me just ask Eric. I mean, Eric, what are you looking to learn from that IVUS? I mean, it seems like everybody wants an IVUS. What are the things that you're looking to learn?
Yeah, I mean, I think the basic stuff, and in this case, it's not as much of an issue, but the first thing is what's the course of the wires, luminal or not luminal? I was thinking about that first. The second is what is the characteristics of the plaque? So is it soft plaque? Is it mixed plaque? Is it calcified? In this case, I'm guessing, and Nick and I were just saying that this is probably going to be calcified, and then we're going to see it better on IVUS than we're seeing on angiography right now. But it'll give us an idea also about eccentric, concentric calcification, and what's the appropriate next device to use. And then also you always get the option for sizing here. So now we're going to better understand what our stent's going to look like. We could size the distal and proximal vessel. PK, your case earlier was a great demonstration. You already had your sizes in place when we asked you because you had looked at them with the IVUS run, which wasn't even meant necessarily to size, but you get that information with that IVUS.
Got it.
Sort of a poor man's gauge of the calcium would be fluoroscopic imaging, which we can't really see here very well with the with the video, etc. But sure, if you can see this on fluoro, that means you have a sizable amount of calcium. Yes, we get a lot of advantage from intravascular ultrasound. But the question I would ask is, this is a very, very large vessel. You know you're going to get good long-term outcomes. Why do you want to use that excessive cost if you don't have a high grade or high amount of calcium in this vessel? And as far as the distal aorta goes, you mentioned, Raj says he would be happy to fix that. But really, with no hemodynamic gradient?
No, I said, I said if there's a hemodynamic.
Okay.
I said I presume there's a hemodynamic
Yeah.
gradient.
Yeah.
across
Okay,
it.
so yeah, there is. But if there's not, then there's no reason
Yeah,
to
then you would just leave it
the
off.
subject that yeah, absolutely. You do hemodynamic measures.
So
Yeah, but you'd have to exercise or do some sort of vasodilatation too.
yeah, but I'm just curious because if you look at this and you say there is a gradient, let's be devil's advocate here. Would it be smarter to convert this to a stent graft and just do a stent graft? Because since you're going to stent both limbs anyway versus a CRAP, and I know that's your talk, but I just want to pick your brain and you and Srini, because I know Srini does a ton of stent grafts as well. So what about you, Raj? Why don't you tell me first?
I mean, I think the data is pretty good for stent graft if the anatomy is suitable. I mean, the renal to the bifurcal length looks okay. I think it's very reasonable. Open it up with a shockwave and then just go ahead and stent graft it.
Yeah, Srini, yourself.
I mean,
Yes,
she's young. She's 60, so I mean, you have many options that you can even play around with. But I think a stent graft might be a good option.
What graft would you use?
Endologic. Well, it's off IFU, but everyone should know that. So yeah.
Srini, anything
I
different?
agree with that in the logics.
Yep. Okay.
Might
Great.
need an extension into the left further down.
Yeah, because George was talking about stenting the right, so you might as well just get it over with and be safe to begin with.
Right.
So George, you heard all the discussion. What do you think?
I'll be honest with you, I couldn't hear it.
Let me tell you what they said. So there was a lot of question about whether there's a hemodynamic stenosis on the aorta. If there is a hemodynamic stenosis on the aorta, they would go ahead and do a shock wave, and then go ahead treat that and the iliac, and then stent both the iliacs and the aorta. Only if there's a hemodynamic gradient. If there's no hemodynamic gradient, they would just take care of the common iliac. They want the IVUS for the level of calcification as well as for sizing of the aorta and the common iliac. One little aside, they did say that a stent graft may be an option, but maybe not the first option. That's all.
Gotcha. Perfect. I'm going to get you some information, PK, in terms of the gradients and get you an IVUS, and I'll be back in just a minute. So what we've done is I've IVUS. So first of all, to get the IVUS up there, I had to use a small 3.0 balloon. Okay. Just to prop it open, and then I went in there with an intravascular ultrasound. Okay. Before I did that, I want to prove to you that I'm intraluminal, PK. So look right here at this picture. This is a glide catheter coming from my left, showing you I'm intraluminal. Okay, because I always had the fear that I'm going to get subintimal. And now I'll show you my IVUS. Jim, can you get an IVUS real quick?
So you can see the aorta is so calcified. It's amazing. It's really, really nasty.
And here we go. Can we play the IVUS form, please? And this is at the level of the distal common iliac, 5.4 by 5.8. We measured. Then hold on one second. Let's just play the end of the loop. We're coming up. This is going to be at the level of the distal aorta. Here we go. Distal aorta. Look how much dropout there is, PK.
Oh my goodness.
So, and then coming back. Heavily calcified, more than 360 circumferential calcium. It opens up afterward, and then we come into that common iliac. The good thing is I think looking at the medial layer of the vessel by ultrasound, it looks as if I've stayed intraluminal. So I feel pretty good about it.
I think the panel agrees with you. They're all shaking their heads that you seem intraluminal, but I think everybody's very surprised at how calcified that aorta is. And really, because we could obviously because of the quality of the video, we couldn't see the fluoroscopic calcium, so it's incredibly calcified.
Okay. No, you're good, bud.
So what I'm going to do is I'm going to take a 6060 shockwave, and I'm just going to prop this distal aorta into that common iliac open and see what it looks like.
So George,
And then distally.
So George, you are going to treat.
Yep.
You are going to treat
that's
the aorta.
In between stents or calcified.
We're gonna cover all that.
Yeah,
anyway.
this is the underexpanded stent.
Yeah.
George, are you going to treat the aorta?
So that's a great question. The question is,
let me stop. Let me measure here.
So we're gonna use say 90 by
Guys,
37 or 40.
Do you hear Dr. Wiley now?
Essentially, this stent is like
Go ahead, George. I'm sorry. Go ahead.
there's another case
It's
getting
very
out.
like
George,
I know you're patched into
At
Montefiore
2:45,
right
we're
now
not ready.
because we are too. We can hear Dr. Wiley as well. But go ahead. Tell me. Are you going to treat that distal aorta?
That's a
15
great
minutes?
question. With a 660 shockwave, I'm going to prep the vessel. And let's
Tell
look.
him to
The
take
question
us
is,
offline.
use
We're
an
not ready.
endologics or something along those lines to preserve that crown. I wanted to see how the iliac responds once I perform balloon angioplasty with the shockwave.
I agree. I think that if you get a good result, you could probably do this with a CRAB, or else you might have to use a stent graft. So while you do that, I'm just going to pick the panel's brain on how they would deal with it. Thank you, George. So Adam, so you didn't see the angiogram. It's basically a distal aortic severe stenosis you saw in IVUS, occluded right common iliac. So when you do shockwave of these lesions, what are some things that you're looking for? Obviously, IVUS-wise, 6 is plenty big, but the aorta is bigger than a 6. So do you go with the largest shockwave balloon, or do you just try to get enough of a lumen and see how the aorta reacts?
Being a newer attending, I'd probably go with a smaller vessel, see what I can gain. I've had a few cases where shockwaves work pretty well, in this setting. If I can break up the calcium, get more compliance to the vessel, then I think I'll have a better chance of being able to get a stent to really oppose that.
Actually, what you're saying is very true. You do have to be careful whether you're new or old. You don't want to rupture the aorta. There's no question about that. I think Eric, you would agree, right?
I'm in agreement about not rupturing the aorta. Every time I use shockwave, I realize that I undersize it, and so I've more aggressively in the coronary, more aggressively in the periphery, gone with the 0.5 millimeter, 8 millimeter larger balloon than I would have chosen. And because if you're not really approximated, you're not going to get that calcium fractures that you're looking for. So I would probably take the 7 millimeter here. I think you're going to be fine. You're only going to 2. You can start at 2, usually have 4 ads, and do a number of treatments. And, it's a low balloon inflation on sizing. It looks like it's bigger than, that by far. So I would probably take a little bit bigger balloon than shockwave.
Yeah. So for Nick and Dr. Jenkins, how are you going to assess your result with shockwave?
Yeah.
Is it imaging, Nick, or is it physiologic with a gradient?
Well, you could do it both ways. The question is what gradient you use, right? The bigger the vessel, the lower the gradient means it's more significant, So a gradient of 10 millimeter here could be very, very significant versus like an SFA or popliteal. But for me, I would look still by IVUS. IVUS is a great tool that you have. I look by how the lesion give away with the shockwave. That's really important. So if you put your shockwave 2 atmospheres and you see that dent on the balloon and you're just using the shockwave, you're doing the pulsation, and suddenly that balloon give away. Definitely that lesion is changing characteristics. You haven't changed the pressure. What happened is the balloon size has changed. So then you go up to the 4 atmospheres, you see another waist. You deliver as much shocks as you want, and then look at this again, and then it gives away again. And every time it gives away, your compliance has changed. And that's exactly what I use. And I've done a lot of those. I think we were part of several of those trials. It probably did over 120 shockwaves, and that's exactly how it behaves.
That's good. That's a great comment.
So we were part of those as well, but the way that you start with a bigger balloon, you use low pressure, and if you keep it at that same pressure, and even though that's most people don't put it at 1 atmosphere, you're not going to rupture a vessel at 1 atmosphere. So number two, the way you tell decreased compliance is that you see your balloon continually at that 1 atmosphere continue to expand to a vessel. Secondly, ultrasound does not have the spatial resolution of OCT to be able to see these microfractures. So you're not going to typically classically look at your ultrasound IVUS to be able to tell what you've done. As long as you see your balloon change in diameter with your however many pulses you deliver, and as long as you use OCT if you want to, but I don't suggest that. I pay taxes as well, and I pay for all these devices. Is this a Medicare patient or Medicaid? So, you don't have to use that expensive technology. You are going to change your compliance using this technology, and that's my comment.
So Raj and Adam, you guys operate on these type of aortas. In terms of when you're operating.
One more comment before I
Sure.
stop. I didn't see the age of the patient, but when George, 60, a younger patient, but when he first mentioned the comorbidities, there were multiple comorbidities, and he was excited about that. So those are the people that you should think that are going to have a lot more calcium as well. Because after all, this is elastic tissue in a human. The older you get, the more comorbidities, the harder. It's just like a tire that dry rots. The older the tire is, the harder, the more calcium, your collagen, connective tissue breakdown, etc. So
Right.
this is set up to be a heavy calcified, except for his age, heavily calcified vessel. I just couldn't appreciate it on the imaging because of the video.
Yep. So Raj, my question to you and Adam, we always hear about friable aortas.
Yeah.
You can dissect up the aorta, you can mismatch and rupture the aorta. In these type, when you're going up with these balloons, to me, looking at that aorta, it's very, very scary because of the eccentric nature of the calcium. Actually, it's concentric, but it's also concentric with eccentric. So that's my worry. So when you operate on this, in terms of when you touch it, feel it, how describe that to us.
It really feels like a rock, right?
Mhm.
And this aorta, you'd be a little concerned operating on, right? Because clamping it would be a little bit challenging, unless you have an area on top, and then you have to do an endarterectomy. If you want to do like an aortoiliac bypass, a fem or something would kind of doesn't make sense on a 60-year-old patient.
Right.
That would not be an aortoiliac retroperitoneal approach would probably be a good option with very good patency. But again, that aorta is, it would just crack the minute you try to clamp it, or you
Right.
may not even be able to find a clamp spot because I'm sure that calcium goes up and down, right? It's not just that focal; it's probably more than what we're seeing. But these are pretty hard, Can you push the calcium out of the wall? Probably, you balloon hard enough, you will.
You can. Okay.
You definitely can. This is fairly rough. It's very tough calcium. I've seen calcium almost, when you look at these iliacs that are diseased, you can almost feel the calcium almost kind of poking out of the adventitia. It's sometimes it's that thin.
Yeah, but to the both of you, when you do a stent graft, you balloon within the stent graft aggressively.
Yeah,
right.
The stent graft.
So here, if you have a calcified aorta up and down, like you said, as a tube, are you secure even with the stent graft to actually expand this? And what is your point that you stop? When do you say, hey, listen, I've achieved enough of a lumen, I'm not going to do any more?
With the stent graft or without?
With and without, both.
With, I guess you'd have to take a pressure gradient. I think you need to modify that plaque first a little bit and make sure your graft actually opens up. Now, once you have a stent graft, if you're not ballooning near the edges of the stent graft, you're probably okay.
Okay.
As long as the size and you have a good seal. It's like a ruptured aneurysm essentially. You should be able to seal if you're in the middle somewhere. Now, if you're ballooning at the edge of the stent graft, that would be dangerous. That if you have a rupture, it's going to be a little bit of a problem, a big problem.
And without?
Without, I think the same thing. I think as everyone said, probably physiologic more.
That's it, more physiologic.
I think that's probably going to be the best. The other option is, I guess you have to have a plan of how you're going to treat this whole thing, anyways, to begin with, right?
Well, yeah.
Are you doing a CRAP here? You look at this like, patient probably had a CTA, I presume, beforehand. Are you planning to do a endologics device or CRAP technique? Then you're going to go for the whole thing.
Got it.
So I think if you have a plan as to how you're going to go, that may help
Got
Aye.
it. Adam, any additional comments on that?
I'll just add, if you're going to do it without a stent graft, I would have one around.
Okay, that's
Prakash, one
Srini?
comment is, even if you have a stent graft, you have a covered stent, you don't have to go to aggressive ballooning. You can have disruption of the collaterals and bleed retroperitoneal. And just because you have a covered stent, that from the aorta itself, it's not 100% protection there. So all you need is a physiologic gradient reduction.
That's interesting. Dr. Ferries, who's our surgeon at Sinai, he says it all the time. Like, don't get this false sense of security because you have a covered graft. You still have to be very, very careful in the way you do it. I know Christian says the same thing. So, George, we're coming back to you, buddy. Why don't you give us a little update on where you are?
Absolutely.
Can't quite hear you.
How about now?
Yep, perfect.
Okay, great. Listen, so had a lot of difficulty getting the shockwave going. I picked a 60 by 60. Come on. And the reason why is I want to see how that iliac responded. And I was 100% sure I wasn't going to be able to get a 7.0 by this lesion. I couldn't get a 6.0 by it. So then I used a 4.0 pre-dilatation balloon, a 4.080, was able to prop it open, and now I've got a 6.060 in there, and I'm treating. Okay? So go up again.
So you have, yep, if I could. Yep.
And then I'm treating at 30 pulses each run.
So the balloon is now in the aorta or the iliac? It looks like in the aorta.
It's in the distal aorta, and I'm going to pull it back into the iliac.
Got it. Are you concerned with having the flush catheter next to it? God forbid it does any damage or ruptures the aorta by being pushed to the side or anything?
I don't think so. I think I think it's pressing it up against the side, but I don't think it's going to rupture. I think it'll give. It's an omni-flush.
Got it.
It's literally just right beside the balloon.
Oh, I agree. It's very soft, but it's just something to think about, I guess. It's another variable to worry about. That's okay.
Yeah, I'm going to pull it back to the iliacs now.
Yeah, if you pull it back and take a picture, we'd love to see where you're at.
What was the pressure gradient across the aorta? Was there one taken just pre-procedural?
Let me ask him. So George, there's a question in terms of the pressure gradient across. Did you get any recordings pre?
I did, and I was too busy trying to get. I've been having trouble with the sheep, and this calcium has been giving me a fit. So I haven't gotten the pressure gradient as of yet.
No problem. I think we'd love to see the aortogram first, and then maybe a pressure gradient.
Great.
After the shock wave goes down. Now, George, how many atmospheres did you inflate the shock wave to? Anything different than what they tell us?
4 to 6 atmospheres.
Okay.
Low pressure.
So Nick and Eric, I mean, do you guys believe that the greatest? They always tell you, right? The center 2 dots. Is that true, or has that been shown by any sort of lab models, or are you aware of that, or is it just all urban legend?
What? What's the question?
They tell, every time I do it in the lab, the rep is always like, those 2 center dots are where you should put it on the calcium to get the most effect. I don't understand how.
Have you not turned the shockwave on in a bowl of water and held it with your hand just to let it tingle your hand?
No, I have not done that.
No? You have arthritis? It might help. Well, you can turn it on and you can see where the shock waves are coming, and you can get it close to the top of a water bowl, and you can see where it makes I always save at least 30 beats to play,
I've always just moved the emitter, so I think it's not as much where I start with and how I approximate. It's that I never leave them in the same place.
I got it.
So after my first run, I would move them up a couple millimeters, move them down, and because the emitters are spaced out on the shockwave balloon, and so you want to hit the calcium in different orientations. So that's always been my approach.
That's exactly what I do too. And but if you can put the emitter where the hardest area of the calcium is, you're probably gonna get better results. Probably.
Got it.
So look for yourself next time. Save 30 pulses and do it in a bowl of water, and you can see exactly where the pulses are coming. So you know.
Yeah.
Good.
So George, I know I saw you finish the shock wave. Can we see an angiogram?
Yep. Getting one for you right now, PK.
Okay, buddy. Thank you.
So how does the panel feel about pressure gradients versus a hyperemic pressure gradient? So if you had a negative pressure gradient here, who would care? Do you do hyperemic pressure gradients in lower extremities? Do you make them do a bicycle on a ergometer on the table? So you,
Not normally.
I mean, what do you do?
We've given nitroglycerin.
Vasodilate.
Yeah, vasodilate. Using nitroglycerin in a minute.
So do you actually do that in aortas?
Not
No,
in the aorta.
I don't.
Really.
I mean, I think if you're concerned, then you probably could.
Yeah,
The lower
but why
extremity,
be
you've done it for that.
concerned? You probably should.
I mean, it's going to look. It's going to be pressure gradient.
Is this
probably.
gonna affect your long-term patency of doing a?
I mean, not if you're. I mean, it depends on how you treat this. I think whatever you put in there is probably going to stay open pretty well.
Oh, look at that.
Yeah, it looks.
Yeah, this looks nice.
Yeah, that looks so much
Yeah.
better, George.
Wow.
So, Steve, really, how much of this aorta is going to respond to vasodilators? I mean, it's just a pure rock. I mean, all the way.
Well, it's not the aorta; it's the distal flow.
The distal
so
flow,
it's
yeah.
the calf, the gastrocnemius, etc.
So George, I just have a question here. Now that you see this, are you changing your mind away from the endologics and maybe doing a CRAB instead?
Yeah, so yeah, exactly. I think the distal aorta opened up pretty nicely, didn't it?
Oh, it's beautiful.
Yeah.
Maybe you might not even need to treat it. I mean, to me,
I
if there's now gradient across that lesion in the aorta, I think you just do a covered stent of the ostial left iliac, and you're done. I think it's gorgeous.
I think you're right. So PK, do you have the faith that I'm not going to have to place one in the right? I'll protect myself, but it's always tough. I just don't want to. You think going up with that calcium right there at the ostium is going to affect that right common iliac?
The panel is mixed. So I think myself and Eric are both saying no.
Probably not.
Dr. Malik is saying no. Dr. Jenkins.
Okay.
So Raj,
Yeah.
leave this. Come on.
So I'll protect myself.
Raj didn't say no.
I think you'll be okay.
I mean, you could balloon protect it.
Exactly.
You could put a balloon up, balloon protect it on the right, and just stent across. I mean, not stent across, stent the ostium of the left, and this way you would save the cost of another, covered stent from Gore. So, which would be great.
So this is an acute angle, however, quite a bit. I think you may end up having to do kissing stents on that one.
So you know what, George. If your gut tells you you can see it much better than us, I think it's simple. You covered stent both, and you're done. The patency is going to be great. I think it's going to create less headache for you.
Great. Absolutely. All right, well, let me get to work. Thanks for the advice.
Does she have any SFA disease or anything that you know of?
So George, any SFA disease that you know of? We can't hear you, buddy.
Oh.
Nope.
No FFA disease or POP. She's got one vessel runoff.
Yeah, that's going to be next. Just get it ready. Yeah.
And two vessel runoff on the left.
Okay, great. So why don't you go ahead and we'll watch you put up the stent and see your final result, and we're going to sign off.
Great. Thanks, BK.
Okay, so I'm just going to wait here. Are you going to deploy the stent right now, or are you going to do something else, some more prep?
Yeah, I'm going to go get a stent right now.
Okay.
Dr. Malik is thinking about that one-stop shopping long-term patency of that talk you just gave.
So, PK, this turned out really good. So, I think you can see the angiogram. This is after a shockwave. Then we took, you can see here, this is the VBX. We're getting it lined up. And we thought we were a little bit too low here. So, we actually moved it up. Right?
Yep.
Look good. And after your advice, PK, we didn't protect ourselves or anything. We just went for the gusto. I took this shot here just to show you that we're above the internal iliac. Okay.
Right.
So then we went up with the stent, and this is what you got.
Oh, wow. Great result, George. Oh, that's awesome.
Look at that.
That's a
Yep.
beautiful result. And what happened with the gradient? I know we had the other panel had talked about gradients. Did you check any gradients?
Yeah, no significant gradient. It was less than 20 millimeters.
Oh, that's awesome. What did you start from above the aorta and come down? And was the aorta significant or not at all?
That's where I started, was it above the aorta.
Oh, that's great, George. Again, I thank you so much. I know it's been very challenging for you and your team. I think all of us here in the audience really appreciate how hard that your team worked in making this happen. I mean, these are not just words. These are really, we mean it. So thank you. Can we have a good round of applause for Dr. Adams and his team? Thank you.
Thanks, PK.
Thank you.